Okay, so today we shall begin with another chapter under the CNS, that is treatment of Alzheimer's disease. Okay, so you all are already aware of what Alzheimer's disease is. You all have studied under your pathophysiology part in CNS chapter of your anatomy. Okay, so before going into the detail, let us see what is the outline of the chapter. We are going to cover the introduction, in which we are going to see in brief what exactly happens in the Alzheimer's disease. Then comes the classification of drugs which are used in the treatment. Next is the cholinergic activators, the drugs which are falling under this category, which is the first class. Then next is the glutamate or NMDA receptor antagonist, and the last class under the chapter is miscellaneous cerebroactive drugs. To start with the introduction, okay, as I have written over here, cognition enhancers or cerebroactive drugs. In the books you will find these names. Okay, so drugs which are used in the treatment of Alzheimer's disease, these are actually cognition enhancers. Okay, so cognition enhancers, or they are also known as cerebroactive drugs. So these are the drugs, the definition of this cognition enhancers, these are the drugs or heterogeneous group of drugs which are developed for the use in the dementia actually. Okay, so dementia or other type of cerebral disorders. So these same drugs which are used in the treatment of dementia are also effective against the Alzheimer's disease. Now we will see in brief what exactly dementia means. Okay, dementia, it refers to acquired global impairment of intellect, memory and personality. That means your cognitive functions. Okay, so here your brain functions are getting affected. Like more importantly, memory may get affected. So there is a loss of memory. Okay, then capacity to solve the day-to-day life problems. Okay, so you normally what happens whenever there is any kind of problem, you have that problem solving capacity, right? So that generally gets lost in this condition, dementia. Then even your performance of the skillful functions may get affected, motor functions may get affected. Okay, slowly they will start declining. Your social skills, you may dislike mingling into the society. Okay, you may remain isolated. Okay, your social interest may also get reduced, and even the control of emotions, these are also primarily affected in this condition, dementia. Okay, so this is to do with dementia. Now coming to this our topic, okay, on which we are supposed to focus, that is Alzheimer's disease. So Alzheimer's disease, as you are already aware, it's a progressive neurodegenerative disorder. Okay, so that means here what is happening progressively, that means slowly what is happening, the brain neurons, okay, neurodegenerative, meaning your neurons in the brain are getting degenerated, okay, or damaged. So there is a loss of neurons in the brains. Okay, so because of this you lose certain functions which are carried out by those neurons, okay, which are lost, whose functions you are losing. That's why all those symptoms will get precipitated. And specifically this disease affects the older individuals. Okay, so this condition will be most commonly seen in the elderly persons. Okay, so as age progresses, all this type of memory loss and loss of skillful performance and all will start getting developed. Okay, and normally it is not very severe, but in case if there is a severe loss or severe degeneration of the neurons of your brain, then it is said to be that the person is suffering from this Alzheimer's disease, and this is the most common cause of dementia, this Alzheimer's disease. So because of the loss of these neurons, your brain neurons, it will lead to this condition dementia, which we have seen, where memory, intellect, your personality, your cognitive functions are getting affected. Okay, so basically what is the pathophysiology lying over here? Atrophy of your cortical and subcortical areas of the brain will take place. Atrophy meaning wasting of certain tissues of the body. Okay, so because of the damage, this brain tissues in your cortical and subcortical regions of the brain, these will be lost slowly. Okay, and why this is happening, why this atrophy is taking place, it's because of the deposition of beta amyloid proteins in the form of senile plaques, and there is formation of neurofibrillary tangles. Okay, so your neurons, they will be degenerated in such a way that the first of all the functions will get affected, the transmission also is getting affected because of this, and mostly the transmission which is getting affected over here is the cholinergic system. Okay, no doubt other transmission, other type of neurotransmissions also may get affected, but the major neurotransmission which is getting affected over here because of this loss of neurons is the cholinergic transmission. So here there is marked cholinergic deficiency specifically in the brain, and that's how all those symptoms will get precipitated. So what should be your target of your drug therapy? It will go towards your improvement in this cholinergic system, which is heavily getting affected in the brain, mainly in the brain. You want the action of this cholinergic system to be enhanced in the brain. Okay, so this theory is put forth because of the underlying cause. Now apart from this, there are several mechanisms by which your drugs may be acting. Okay, so several theories have been put forth how it can cause the improvement in the other symptoms of your Alzheimer's disease. Okay, so those symptoms which are precipitated or progressively those are increasing. So how to control those symptoms? So these can be improved by several mechanisms which have been put forth. So these cerebroactive drugs actually were found to be acting by increasing the global or the regional cerebral blood flow. Okay, meaning the blood flow to the brain is increased either globally, meaning entire region in your brain or whole brain, the blood flow was increased, or there is regional increase in the cerebrum, meaning in certain areas of the brain. Okay, so this could be one of the mechanism by which the cerebroactive drugs could improve these symptoms. Next mechanism of action which was put forth is direct support of neuronal metabolism. Okay, so the neuronal metabolism may be improved by certain drugs. Next is enhancement of the neurotransmitters, which we were talking about, cholinergic transmission which is getting affected. So enhancement of these neurotransmission, specifically of the cholinergic transmission, is one of the mechanism of action. Then improvement of discrete cerebral functions, say for example memory. So certain drugs are targeted towards improvement in the memory, so that forgetfulness which is produced. Okay, so person's memory may get severely affected over here, so that the person may not even be able to identify the people. Okay, so it may be that severe also sometimes. Okay, so certain drugs also help in improving the memory, so that the person can remember things well. Okay, so these are the several targets, okay, by which these cerebroactive agents could show their therapeutic effect. Now, one theory was put forth that the first mechanism we have seen, that the flow to the brain was increased, right, either globally or in certain areas of the brain. Okay, so generally when these cerebroactive drugs, it was believed that increase in the blood flow could show marked improvement in the symptoms of Alzheimer's disease. Okay, so this was a assumption. Okay, improvement in the cerebral circulation. This is possibly responsible for the therapeutically usefulness of these drugs. Okay, but later on it was found that just merely by increasing the blood flow to the brain, could improve the symptoms. Something not very much clearer. How could only increase in the blood flow result in improvement in all the functions of your brain? That is practically not possible, right? Even in case, if say in case of stroke, if a person is suffering from stroke, global vasodilator action, that is increase in the blood flow, may even be harmful. Okay, it can worsen the cerebral edema. Steal phenomenon may also be precipitated, like flow of your blood from the non-ischemic areas, it may be shifted to the ischemic areas. So several deleterious effect also could be produced. Okay, no doubt blood flow to the brain is reduced in Alzheimer's disease. It is seen that the cerebral blood flow is reduced, but probably why that blood flow is reduced? It's because of the loss of the neurons. Since the brain mass is getting lost, certain neurons, their functions and they are getting degenerated, so certain neurons in your brains are getting lost. So that's how the blood flow is actually reducing. It's not a basic pathology which is responsible for Alzheimer's disease. That is, decrease in the flow only will not result in the Alzheimer's disease. Okay, so that's why this theory doesn't sound to be very much appropriate, that only increase in the blood flow to the brain would improve all these symptoms. Okay, so that's why several other approaches also have been put forth. Okay, out of this transmission, effect on the transmission is an important point over here. If you can see in the classification of the treatment, we can see the first class is cholinergic activators. Okay, so transmission, the cholinergic transmission which is getting affected, which is responsible for the basic pathophysiology of the condition. So our target should be towards improvement of this cholinergic transmission. So first class which was introduced was cholinergic activators. Now if you can see the examples, tecrine, rivastigmine, donepezil and galantamine, these are actually anti-cholinesterase drugs. Okay, so these drugs will inhibit the enzyme cholinesterase, which is responsible for metabolism of acetylcholine. Okay, but the name given over here is cholinergic activators. That means they will enhance this particular transmission. They will prevent the degradation of acetylcholine. That's how they will result in the activation of this system, cholinergic system. Okay, so only these four under this anticholinesterases in your ANS chapter, we have seen that there are several examples of these drugs which can inhibit the metabolism of acetylcholine, thereby they will potentiate the action of acetylcholine. But over here only 4 examples are given because these are selective towards the action in the brain. Cerebroselective, these are 4. So these are the only 4 which is effectively used in the Alzheimer's disease. We will see in under the individual drugs. Okay. Then the next class under this chapter is glutamate or NMDA receptor antagonist. Glutamate is an excitatory transmitter. So receptors through which this glutamate produces its action, so they can be antagonized. So that's how it shows the improvement. Example is memantine over here, only one example. And the third class is miscellaneous cerebroactive drugs. Over here there are several examples. Piracetam, then pyritinol, this is also known as pyrithiopsin. Next example is dihydroergotoxin or codergocrine is another name for this drug. Then next drug is citicoline, pyribedyl and ginkgo biloba. So there are several miscellaneous agents which have been recently introduced. Coming to the first class, that is cholinergic activation. Since we have seen under the pathophysiology part, brain acetylcholines are markedly reduced. Okay, so cholinergic transmission is the major transmission which is getting affected, and that lies under the pathophysiology of the Alzheimer's disease. AD is the accepted short form for Alzheimer's disease. Okay, so that's how, because of the discovery of this basis in the pathophysiology of the Alzheimer's disease, several approaches were found out to improve the brain ACH levels. Okay, now how you can improve the brain ACH levels? Now this is what is happening normally to your acetylcholine. Before going into the different approaches, acetylcholine is actually a neurotransmitter, you are already aware of. Okay, so it is stored in the form of vesicles. This we have already covered under the ANS chapter. Okay, so acetylcholine which is stored in the vesicles, as and when the signal arrives, this acetylcholine will be released in the cleft. It may go and bind to its effector organs, or it may released and it will go and stimulate the next neuron, so the signal will get transmitted. Okay, so this ACH which is released, which is responsible for the normal functioning, certain functions or physiological role ACH plays in your brain. Okay, so what happens with this ACH in your brain? Transmission is getting affected, meaning here these neurons which are belonging to your cholinergic system, these are majorly affected. So what will happen to the stores of ACH? Stores of ACH will get depleted. Okay, so functions pertaining to the release of ACH will get affected. Now normally when ACH is released in the cleft, it will act onto its receptor and it will further transmit the signal. So after some time what happens, this ACH which is released in the cleft, it will get metabolized. Okay, so it will get metabolized. Acetylcholine, ACH, it gets metabolized with the help of acetylcholine esterase, ACHE. Now this choline esterases, these are of two types. Okay, one is the acetylcholine esterase and the second one is butyrylcholine esterase or pseudocholine esterase it is known as. So this enzyme ACHE or acetylcholine esterase specifically is responsible for the metabolism of ACH. It is selective towards metabolism of your acetylcholine, whereas butyrylcholine esterase is responsible for metabolism of other type of esters which are present in the body. So this ACHE or acetylcholine esterase is found in the cleft. So once the function of ACH is over, this enzyme will quickly act on this ACH and it will hydrolyze this enzyme. This is the process of hydrolysis. Your ACH will get bound to this enzyme. Okay, this enzyme will get acetylated and it will be hydrolyzed. With the help of water, it will split your acetylcholine into acetate and choline, that is CH. Okay, and acetate will further get metabolized into carbon dioxide and water, and this choline which is generated over here, it will be taken back by the neurons for the regeneration of fresh molecules of your acetylcholine. And these acetylcholine molecules which are generated, it's a two-step reaction actually. Okay, so this acetylcholine which is generated, it is taken back and stored by your vesicles for your further use. So this is what is happening normally. So from this process we can see that there are several targets which you can follow to improve your brain ACH levels. First of all, precursor loading was done, like choline or lecithin, which are the precursors for generation of ACH. Okay, choline, these were administered, but then it was found that choline levels were normal in the body. Okay, it's only the ACH levels which are getting affected. Choline levels were normal in the body, so there was no point in administering the precursors to that particular patient. Okay, so this theory was ruled out. Next, cholinergic agonists were tried. Okay, now cholinergic agonist meaning, under the chapter we had seen under ANS, it is divided into two parts: cholinergic agonists and anticholinesterases. This is the second class. So cholinergic agonists were also tried, right? Eracolina, the example, bethanicol, oxotrimorin. So these are the examples of cholinergic agonists, meaning what these drugs will do, these will just like ACH, they can also go and bind to the cholinergic receptor, nicotinic and muscarinic receptor. They can also go and bind to the receptor and stimulate them in the similar way just like your acetylcholine. Okay, so these were also tried, okay, but then they were also not found to be very effective. Okay, and later on these anticholinesterases were tried. Okay, neostigmine, physostigmine, if you can remember. Okay, there are irreversible inhibitors, reversible inhibitors, carbamates. Okay, so there are several examples over there. Okay, now out of these, now actually all the anticholinesterases were not effective. Rather, all the anticholinesterases were not cerebroselective, meaning they could inhibit this metabolism of ACH in the periphery also. Okay, so because of inhibition of this ACH metabolism in the periphery, what will happen? The amount of ACH or the concentration of ACH in the peripheral cholinergic system, that would also increase. But is that what you are expecting over here? Which area is getting affected? It is the brain cholinergic system which is getting affected over here. That's responsible for the loss of function, many of the mental functions. Nothing is happening to your peripheral cholinergic system over here. Okay, so those anticholinesterases which have more of peripheral actions, they were not found to be very much promising in this treatment of Alzheimer's disease. Okay, so they were rather producing more of marked peripheral side effects. Okay, cholinergic side effects were precipitated because of these anticholinesterases, which are not cerebroselective. So later on, it was found out that there are 4 cerebroselective anticholinesterases. Okay, anticholinesterase meaning those drugs which can inhibit the enzyme acetylcholinesterase, which is responsible for metabolism of ACH. So when you inhibit this enzyme, what will happen? The amount of ACH will remain high over here. So ACH immediately, once it is released, it gets metabolized. Okay, so when you give anticholinesterases, it will not metabolize. Okay, so rather it will block the metabolism. By inhibiting this enzyme responsible for hydrolysis of ACH, it will make the ACH prevalent in your cleft. It will act for a longer period of time, or it will potentiate the action of your ACH. And what kind of anticholinesterases we want? We want the cerebroselective anticholinesterases. This is what is required, because it is the brain cholinergic system which is getting affected. So there are only 4 anticholinesterases which are cerebroselective, and only these 4 can be effectively used in the treatment of Alzheimer's disease. Rest will only start precipitating the peripheral side effects. Okay, so coming to the individual drugs, tecrine was the first centrally acting anticholinesterase which was introduced for the treatment of this Alzheimer's disease. Okay, so it showed the improvement in several modalities which were getting affected, right? Memory improved, attention span was improved. Okay, praxis meaning the performance of skillful motor functions, reasoning, okay, language. So all these symptoms which were precipitated in Alzheimer's disease, they were improved. Okay, so only symptomatic improvement is seen over here, but it does not alter the underlying disease process. So the basic pathophysiology was not getting affected. Okay, so only disease progression was getting affected. The decline which was precipitated due to Alzheimer's disease, that was controlled. Okay, it was slowed down by this tecrine. Okay, but the problem with this tecrine is it used to produce several cholinergic side effects, and major one was the hepatotoxicity. It is quite toxic to the liver, so that's how the use of this tecrine is limited. Next drug which was introduced was rivastigmine. Okay, so it's a carbamate derivative of physostigmine. So it inhibits both acetylcholinesterase. ACHE is acetylcholinesterase and BUCHE is butyrylcholinesterase. Okay, so it inhibited both the type of enzymes. Mind it, this is the main one. If this enzyme is inhibited, it should be more selective towards acetylcholinesterase. Okay, if it inhibits this butyrylcholinesterase, it will inhibit the metabolism of other esters also. Okay, so we want to inhibit this enzyme. So it was found to be more selective towards the inhibition of G1 isoform of the ACHE that mainly predominates in certain areas of the brain. So this drug rivastigmine selectively inhibited the ACHE in the brain. Okay, so that's what is the plus point. And so also its lipid solubility was very high, so that could enter very easily in the brain. As you are already aware that drug which is highly lipid soluble can only enter the brain very easily, because blood brain barrier is highly lipoidal in nature. So any polar substance cannot gain access to your brain very easily. So this was a plus point with rivastigmine. It is highly lipid soluble, so it can enter the brain very easily, and also it is selective towards the isoform of ACHE which is selectively predominating in the brain. So that's a plus point. So what this rivastigmine is doing, it is carbamylating the enzyme. So this is your enzyme. If you can remember, this is a picture which we had seen in your cholinergic system also. Okay, so this is the enzyme Okay, so this enzyme gets carbamylated. So generally acetylcholine, when it gets hydrolyzed, it gets acetylated. This enzyme will get acetylated over here at this position, and further when water acts, it will immediately release the acetate and the choline. It will be set free, and the enzyme will be free for hydrolysis of the next molecule of ACH. That's what we have seen under the ACH hydrolysis. But what happens when drugs like rivastigmine bind to this? Okay, so they carbamylate. So this carbamyl residue will bind to this enzyme. So this enzyme will become a carbamylated enzyme. So over here, when water comes, okay, for hydrolysis to take place, this process takes place very slowly. Okay, so generally when that enzyme will set free, once it is hydrolyzed with the help of water, and this carbamyl group which is introduced in your enzyme, that will be set free. Okay, so now your enzyme is free now. Okay, and that carbamyl group which was introduced over here, it is set free because of the hydrolysis. But you can see over here, slow reaction. So whatever that this rivastigmine has attacked your enzyme, okay, it is not getting hydrolyzed very quickly. Okay, so it takes time for this carbamyl group to leave this enzyme. So this enzyme remains occupied for a long period of time, so that ACH will not be hydrolyzed by this carbamylated enzyme. That's the mechanism of action which we have seen. So if you can see over here, the cerebral ACHE, it remains inhibited for round about 10 hours. Okay, so this is inhibiting the enzyme for even prolonged period of time. We have seen that even by the time new enzymes may get stimulated, formed. Okay, though the T half-life of your drug is just 2 hours. Actually, rivastigmine's T half-life is just 2 hours. Okay, so it will get metabolized very easily. But if you can see, the carbamylated enzyme is not set free very easily. Up to 10 hours it will remain, it will keep this enzyme inhibited, so that ACH will not be hydrolyzed. So that's how it is potentiating the action of your ACH. Okay, so this is the mechanism of action of rivastigmine. So because of this property, it is improving the symptoms like apathy. Apathy meaning lack of interest or enthusiasm. Then delusions. Delusions meaning false belief about something. Meaning you will always have a feeling that people are talking about me. Okay, though they are not talking actually about you, but you will have that false belief. Oh my God, no, they are talking about me. Okay, so you have certain false belief, okay, of your own, which are actually not correct. That is the meaning of delusions. Then hallucinations may also be improved, or agitation. So these symptoms may be improved, but again over here disease progression is not affected. Okay, so basic pathology may not be affected, but it will show the symptomatic improvement. Cholinergic side effects also with this drug are lower as compared to tecrine, and there is no liver damage seen, which is a limitation of tecrine. So this drug is found to be safer, and also it is found to be a longer active one. Coming to the next drug, that is donepezil. Okay, so this is again cerebroselective agent, and it is a reversible anticholinesterase. Okay, so it will show improvement in both the types, like which is associated with dementia and the one which is not associated with dementia also, and the improvement will last up to say 2 years. So it will the patient will remain benefited for around up to 2 years of period. Okay, so it's quite long acting drug, and it is also showing improvement. The prolonged improvement is shown by this particular drug. Okay, so here it elevates the ACH. Because of this anticholinesterase action, it will elevate the ACH level in the cortex. So whatever surviving neurons are there, they will immediately take up this ACH and they will store it in the especially those neurons which are projecting towards your cerebral cortex and hippocampus. Okay, and another plus point is that at therapeutic doses, only weak peripheral anticholinesterase inhibition is seen. So peripheral side effects are, or cholinergic peripheral side effects are also milder with this. Even it is not hepatotoxic. Okay, so no hepatotoxicity is seen. So again, this is an advantage. If you can see the T half-life of this drug, it is around about 70 hours. So it is quite a long-acting agent, so that only once daily dosing is sufficient. A single daily treatment is sufficient. When you compare it with rivastigmine and galantamine, these drugs are short-acting, so twice daily dosing is required. Maybe 2 doses are required per day, but that is not the case with donepezil. So only 1 dose is sufficient with this drug. Coming to the next drug, that is galantamine. This is a natural alkaloid which again selectively inhibits the cerebral ACH. Okay, so selectively brain acetylcholine esterase is inhibited. And apart from this, an additional mechanism is that it can also have some direct agonistic action also on the nicotinic cholinergic receptor. So this galantamine, no doubt it will inhibit the metabolism of ACH, plus it will also have the agonistic action on the nicotinic receptor. Okay, so itself also it can stimulate the nicotinic receptor. Okay, so again galantamine also produces improvement in cognitive functions, or behavioral improvement is also seen over here with this galantamine. Again, this drug is also well tolerated, less number of side effects, but as we have seen, the T half life is short, so twice daily dosing is required over here. Okay. So if you can see all these agents, okay, now out of this, tecrine is not very popular because of the hepatotoxicity, but rivastigmine, donepezil and galantamine, all these 3 afford the similar kind of improvement, but symptomatic improvement in the Alzheimer's disease. That is, whatever cognitive decline which is produced, that is slowed. Okay, but it is not totally prevented. Okay, but it will slow down the progression of the disease. Okay. Then coming to the next class, that is glutamate or NMDA antagonists. Only one example is given over here, that is memantine. So this drug, as the name implies, how this will act, it is acting by blocking this receptor, glutamate receptor or NMDA receptor. This also we have seen in our earlier chapters, also in the CNS we have seen, in the Parkinson's disease also, anti-Parkinsonian drug also we have seen, right, amantadine. Okay, so that is the drug which also blocks this type of receptor, glutamate receptor. Now glutamate receptor, these are excitatory type of receptors found in the brain. So by blocking this excitatory receptor, this memantine, it blocks the excitotoxicity of this transmitter glutamate. Okay, so this is how it shows the effectiveness in the Alzheimer's disease, and it is again showing the symptomatic improvement in moderate to severe Alzheimer's disease. Okay, so mechanism is by blockage of the glutamate receptor, which are the excitatory type of receptors. Okay, again this drug is also having mild side effects. Okay, it is better tolerated drug, even better as compared to the anticholinesterases, which is the previous class. Okay, so side effects, if you can see, these are mild constipation, tiredness, headache and drowsiness. Okay, so these are not very severe kind of side effects which are seen with the memantine. Okay, again this drug is indicated into only the moderate to severe type of Alzheimer's disease. Only symptomatic improvement is seen with this particular agent.